So we're going to finish our session on drugs that act within the peripheral nervous system, looking at the drugs that act within our somatic nervous system. So to remind ourselves, this is the nervous system that controls our, or the component of the peripheral nervous system that controls our skeletal muscles. Anatomically, it consists of motor neurons that have their cell bodies in the central nervous system, like in the spinal cord, and then their axons, a single axon projects out to the effector, which is always skeletal muscle. And these somatic motor neurons release acetylcholine and large myelinated neurons that conduct impulses very rapidly. So we've got very rapid control of our movements. Now, this somatic division of our peripheral nervous system is all under our conscious control, and so we can have various gross and precise conscious muscle movements, and also some relatively unconscious aspects of this muscle control, like controlling posture and respiration, though you'll note all the same muscles can be consciously controlled if we choose to. You can hold your breath if you want to. So drugs that work within the somatic nervous system would generally be those that are used to block neuromuscular transmission and so induce paralysis. So a muscle relaxation and paralysis. And the main use for this is as an adjunct to anaesthesia in surgery, where causing all the muscles to become flaccid will help to limit the damage being done while incisions and things are being made. So much easier to make incisions and cut through relaxed muscles or cut around relaxed muscles than contracted ones. Now, because paralysis is obviously not a very healthy or life-promoting state to be, you usually will have these drugs be reversed with another group of drugs called anticholinesterases. Not to be confused with your anticholinergic drugs. These are anticholinesterase agents that reverse neuromuscular blockade so that you can relieve that paralysis as soon as possible, because while that paralysis is active, you have to use things like ventilators to cause breathing to actually occur, because you can't do that without your skeletal muscle activity. So our somatic synapses are your neuromuscular junctions. So at neuromuscular junctions, acetylcholine is released, as we've said, but here it acts on nicotinic receptors rather than on muscarinic receptors like the parasympathetic acetylcholine. Those nicotinic receptors are found on the motor end plate, the surface of the muscle fibre, and their stimulation leads to muscle contraction. Now, acetylcholine has only a brief action per nerve impulse because it's rapidly broken down by the enzyme acetylcholinesterase, which breaks it down and stops the acetylcholine action at the neuromuscular junction. Otherwise, the release and metabolism of acetylcholine is the same as what occurs for the autonomic nervous system that we've already described earlier, just being different in that it's acting on nicotinic receptors rather than muscarinic receptors. So if we look here at our neuromuscular junction, now this axon terminal is drawn large very purposefully because these neuromuscular junctions are giant synapses compared to the rest of our synapses. So they're much bigger, the amount of acetylcholine released is huge, and there's something like 1 million receptors per neuromuscular junction, and one neuromuscular junction for every single muscle fibre, every single muscle cell that you have. So acetylcholine gets released and acts on these postsynaptic nicotinic receptors and also on presynaptic nicotinic receptors. Nicotinic receptors are ligand-gated ion channels in the membrane of the cell, and when open they allow passage of sodium to go through. So acetylcholine activating postsynaptic receptors causes a sodium influx into the muscle cell, and that's going to lead to depolarization and triggering of a muscle action potential, which will in turn trigger muscle contraction. We also have presynaptic nicotinic receptors, which again allows sodium ions into this time the presynaptic end bulb, and there it will cause further depolarization, just like the arrival of the nerve impulse did, and potentiate the release of acetylcholine. So these help there to be this absolute flood of acetylcholine release that's required to activate 1 million acetylcholine receptors or 1 million nicotinic receptors on the muscle. So we use drugs here to block this neuromuscular transmission, where you're looking to then induce paralysis or induce muscle relaxation. And there's a number of different sites at that neuromuscular junction where you could disrupt that neuromuscular transmission. So you might want to block the generation of an action potential in the motor neuron. You might want to inhibit release of acetylcholine, or most commonly block the postsynaptic receptors. As well as this being a site of action of a number of drugs, some of these drugs have actually been derived from naturally occurring toxins. So all animals have these same or very similar neuromuscular junctions, and a lot of other organisms that have evolved alongside us have evolved toxins that are able to block neuromuscular transmission to induce paralysis. So of the drugs we use, we divide the neuromuscular blocking drugs that stop acetylcholine to the muscle contraction to induce muscle relaxation. We divide these into two key groups: our non-depolarizing neuromuscular blocking drugs and our depolarizing neuromuscular blocking drugs. Now, the non-depolarizing are simply nicotinic receptor antagonists. So these block the action of acetylcholine at both post and presynaptic nicotinic receptors in a competitive way. So blocking the postsynaptic receptors blocks the muscle contraction. Blocking presynaptic receptors also means there's less acetylcholine to compete with that antagonist because there's been less released. So this will then mean that you don't have the activation of postsynaptic receptors to cause muscle contraction. Drugs that work like this include tubocurarine, which isn't really used anymore, but we mention because it's kind of the archetype. Tubocurarine is derived from the plant poison curare. This has been used traditionally by some indigenous South American tribes as poison for arrow tips in hunting. So they'd use it to induce paralysis in animals that they've hit with these poison arrows. And investigations using that curare, that tubocurarine comes from, was actually where we got our first understanding that there was such a thing as a synapse, that electrical activity from nerves and electrical activity in muscles wasn't absolutely continuous but had a chemical component in between. It was by observing the effects of that particular toxin that we first understood that the nervous system uses chemical transmission. These days we use a variety of synthetic analogues of that in order to mostly induce paralysis during surgery. We do also have depolarizing neuromuscular blocking drugs, which surprisingly when you first think about it are nicotinic agonists. So these activate nicotinic receptors. So you go, okay, wouldn't nicotinic receptor activation lead to muscle contraction? Very briefly for a moment it does, but normally the way our neuromuscular junction works is you get a brief activation of nicotinic receptors and then you set off a muscle action potential and then you break down all the acetylcholine, and all this happens in the course of, a millisecond or so. And then you allow the acetylcholine receptors to close, the muscle cell membrane repolarizes and is prepared to do another muscle action potential. These nicotinic agonists don't get broken down by acetylcholinesterase at the neuromuscular junction, so they keep the nicotinic receptors activated. That means the muscle cell membrane stays depolarized, which means it can't repolarize to prepare for another muscle action potential. So you'll get one muscle action potential, but then you can't make another one. And so you're blocking neuromuscular transmission by keeping the muscle cell depolarized. We only really have one of these that we use, succinylmethonium, and this is used just for its very brief action as a nicotinic agonist. It's able to induce activation of nicotinic receptors and first a momentary contraction that's not even noticeable, and then paralysis or relaxation of those muscles. And it's a very short-acting agent that our body quickly destroys. So we use this just for things like endotracheal intubation, so where you need to give a brief moment of paralysis in order to stick a tube down someone's throat, and other needs for very brief episodes of muscle relaxation. We don't use any of these that act for a longer term because we don't have any way of being able to reverse their effects, whereas the non-depolarizing agents, we can reverse their effects with these anticholinesterases, also known as acetylcholinesterase inhibitors. So these block the enzyme acetylcholinesterase. That's the enzyme that normally breaks down acetylcholine at the neuromuscular junction and at other cholinergic synapses too. So these then stop you breaking down acetylcholine and then increase the endogenous acetylcholine at the synapse. So they'll reverse the effect of neuromuscular blocking drugs, where those drugs were blocking nicotinic receptors in a competitive way, so up the amount of acetylcholine, and that will outcompete the antagonist. And that can quickly reverse neuromuscular blockade and quickly reverse paralysis after anaesthesia. So you don't have to keep people on ventilators longer term as you wait for the non-depolarizing drugs to wear off. They also have some other limited clinical use in things like glaucoma, myasthenia gravis, where you've got damage to neuromuscular junctions and muscle weakness that results from that, and somewhat in Alzheimer's disease as well, to control some of the earlier symptoms at least. We also note that there's a lot of acetylcholinesterase inhibitor toxins out there as well. For example, organophosphate pesticides are irreversible inhibitors of acetylcholinesterase, and so can cause quite an ugly and severe poisoning syndrome, where you get paralysis and also all this autonomic activation as well, and stimulation in the central nervous system too, from basically not being able to break down any of your acetylcholine, so stimulating all of your cholinergic receptors simultaneously. Also common in a variety of chemical warfare nerve agents, for those to be acetylcholinesterase inhibitors too. But we use ones that are not irreversible, but are competitive inhibitors for the actual drugs that are anticholinesterase the anticholinesterase agents. So these will have a relatively short-lived effect, and the appropriate doses will simply reverse neuromuscular blockade rather than causing all of those damaging toxic effects. So this figure here summarises those drugs affecting neuromuscular transmission. We've got our neuromuscular blocking drugs, some that are competitive and block the channels or block acetylcholine binding to the channels, so then you don't get muscle action potential. We've got our depolarizing succinylmethonium that binds to the receptors but stays bound there much longer than acetylcholine can, because it's not been able to be broken down by acetylcholinesterase, and will bind and then slowly dissociate, leading to a brief episode of paralysis, because first sodium will get through, but then also as sodium gets through, first you'll get depolarization of the muscle, but it will stay depolarized, and so you could only get the briefest moment of contraction before it stays depolarized and then relaxes. We also have here the anticholinesterases that are going to potentiate acetylcholine's activity at this synapse, usually used just to reverse neuromuscular blockade. And noted also on this figure are some agents that reduce acetylcholine release. A good one to notice there is botulinum toxin, aka Botox, which is used to paralyze certain muscles locally, for example around the face, to relieve wrinkles and things like that. By preventing acetylcholine from being released, it stops the actual exocytosis process from happening, and does so in a long-lasting way that takes, some months to recover from. And that's used not just for cosmetic purposes, but also for relieving muscle spasticity, and also can help to block acetylcholine release at sweat gland synapses as well, and so relieve excessive sweatiness, particularly in hydrohidrosis, so a syndrome of excessive sweating. So, bringing us to the end of our lecture here, what you want to do this lecture is very much first review the normal physiology of the peripheral nervous system, paying particular attention to which neurotransmitters are in which part of the peripheral nervous system and which receptors those neurotransmitters act on in which part of the peripheral nervous system, what effects can be mediated from each receptor type, and then most of what else you have to do is simply go, is this drug an agonist or antagonist, and which receptors is it an agonist or antagonist at? And I'll see you guys in the next session.